Let's dive into this case with a confident approach. As I start analyzing these selected CT images, the first thing that catches my eye is the well-defined lytic lesion in the left pedicle and left side of the vertebral body of L3. The cortical margins of the spinal canal seem to have been breached over a short segment on the axial images, which immediately raises concern for something more sinister. Given the location and the lytic nature of the lesion, my differential diagnosis leans heavily toward a metastatic process, myeloma or lymphoma. The fact that the lesion is well defined and has breached the cortical margins suggests an aggressive process, which aligns with these differentials. Myeloma is particularly high on my list, considering it often presents with lytic lesions in the spine, and it's not uncommon for these lesions to involve the vertebral bodies. Interestingly, there aren't any other lesions visible on these images, which makes the solitary nature of this finding particularly important. If this were a metastatic lesion, we might expect multiple lesions, although a solitary metastasis is certainly possible. The involvement of the spinal canal is worrying because it can lead to compression of the spinal cord or nerve roots, which would require urgent attention. To confirm my suspicions, I would advocate for a CT-guided biopsy, as shown in the final image where a needle is already positioned within the lesion. This biopsy would provide the definitive diagnosis, allowing us to distinguish between myeloma, metastasis, or another type of lesion, such as a lymphoma. In terms of management, if this lesion is confirmed to be myeloma, the patient would likely need systemic therapy, possibly including chemotherapy or targeted therapy, depending on the specific subtype and staging. Additionally, if there's any evidence of spinal cord compression, this might necessitate surgical intervention or radiotherapy to prevent or alleviate neurological deficits. Now, anticipating some follow-up questions from the examiners, one might ask: 1. What are the potential complications of this lesion? The most significant complications would include pathological fracture of the vertebra, leading to spinal instability, and spinal cord compression, which could result in neurological deficits ranging from radiculopathy to paralysis. 2. How would you manage spinal cord compression if it were present? If spinal cord compression is confirmed or highly suspected, this would be a surgical emergency. The patient would require urgent decompression, possibly through laminectomy or vertebroplasty, depending on the extent of the lesion and the patient's overall health. Corticosteroids might also be administered to reduce inflammation and edema. 3. What are the radiographic features that would help differentiate between myeloma and metastatic lesions? Myeloma typically presents with punched-out lytic lesions without a sclerotic rim, often involving the axial skeleton. In contrast, metastases can be lytic, sclerotic, or mixed, depending on the primary tumor. For example, prostate cancer typically causes sclerotic lesions, while renal cell carcinoma causes lytic ones. Myeloma lesions also often spare the posterior elements of the spine, which might help in differentiation. 4. Why is it important to identify whether there are multiple lesions? Identifying multiple lesions would be more indicative of a metastatic process, which would guide the search for a primary malignancy elsewhere in the body. Multiple lesions would also alter the staging and prognosis significantly, impacting treatment decisions.